Good morning, everybody, and you're very welcome to Research Bites. We're back after a little break. This morning we have Associate Professor Clare Corish. So Clare's background is in human nutrition and dietetics, and she's extensive experience in dietetic practice working in Ireland, the UK, and Saudi Arabia. And then she's also had a lengthy experience from an academic point of view with her teaching and research experience in clinical nutrition and dietetics. So Clare is Associate Professor in Clinical Nutrition at UCD, and she established a professional graduate program in clinical nutrition and dietetics. Her research focuses on disease-related malnutrition or malnutrition in the older person, early childhood, and lifestyle among shift workers. So she serves on many expert committees, professional and regulatory bodies. So we're delighted to welcome Clare this morning. So over to you, Clare.
All right, thank you very much, Dolores. That's great, and hopefully my voice lasts out. I was saying to Dolores and Geraldine that I've had the clinical nutrition this morning for the last 2 hours. So anyway, it's our last class of term. So what to present to you today is then on the ONS project, which is one specific project that we have. And really, I suppose I'm presenting on this project really on behalf of all of the ONS Pres researchers who've worked on the project over the last couple of years, and our co-applicants and collaborators. And the background for this project, really, I suppose, for getting the funding for this project was that I had previously supervised a PhD student in the Midlands of Ireland who had, as her PhD project, devised and developed an education for GPs and community and public health nurses around the management of malnutrition that was shown to be very effective. And also I had just finished the Malnutrition in the Elderly project, which was an EU project, which I was working on in collaboration in UCD with Eileen Gibney. So firstly, what is malnutrition? So malnutrition is a condition which is diagnosed based on the presence of at least one phenotypic criterion and on at least one etiological criterion. And the phenotypic criterion are weight loss, or percentage weight loss, low BMI, and then reduced muscle mass and function and structure. The etiological criteria include reduced food intake, or problems with assimilation or digestion, and the presence of inflammation, which can occur generally as a result of a disease state in developed countries. And the at-risk groups that we see in Ireland and the UK and developed countries are those who are older adults with chronic conditions. And the consequences of malnutrition really, I suppose, are summarised here. So they're at greater risk of all-cause mortality, longer hospital stays, more likely readmitted to hospital, loss of independence and reduced quality of life. And although the true prevalence is difficult to determine, it is estimated that about 10% of the population requiring care from a GP is at risk of malnutrition, with an annual cost associated with malnutrition of about 1.4 billion in Ireland. So the management of malnutrition really is preventable and manageable. And the first line management or treatment is food first advice. So consuming foods with a high nutritional value and increased snacking. And if food first advice is unsuccessful, really we're looking at the prescription of oral nutritional supplements. And appropriate prescribing of oral nutritional supplements requires regular monitoring every 3 months to assess compliance and continued need. However, we know that in Ireland, from the previous work we did, that the management of malnutrition community is suboptimal, that inappropriate prescribing is common, and social factors are often influence the need for ONS. So for this study, which we call the ONS Pres study, we investigated the clinical, social and other factors that influence malnutrition management and ONS prescribing by Irish general practitioners and other healthcare professionals. And then we took our findings and developed an online education module to support evidence-based, patient-centred malnutrition management and ONS prescribing. And the project was funded by the Irish Health Research Board. So the first thing we did, we conducted a number of literature reviews. So the first literature review was a systematic scoping review of interventions to improve appropriate prescribing of oral nutritional supplements in primary care. The interventions ranged from dietitian-led reviews of patients prescribed ONS to the transfer of ONS prescribing privileges from GPs to dietitians. In general, unfortunately, reporting of the interventions was poor and the studies lacked controlled and experimental design. But nonetheless, the interventions indicated that there were improvements in ONS prescribing based on study-specific definitions of prescribing appropriateness and absolute reductions in prescribing, as well as some cost savings. And this paper was published in Clinical Nutrition in 2020. We then did another literature review, which is second literature review, which was an investigation of community dwelling older adults' opinions about their nutritional needs and their risk of malnutrition. So our findings indicated really that older community dwelling adults followed the same dietary advice as recommended for the general population, despite their nutritional needs being a little bit different than those of the general population. Weight loss among older people was seen as positive and normal rather than a cause for concern. And the major barrier to food intake was lack of appetite. And I suppose what these findings show was that older adults are unaware of the risks and consequences of malnutrition. And this paper has also been accepted for publication in Clinical Nutrition, which is great because Clinical Nutrition is a really high impact journal, and it went online in December 2020. So the two literature reviews have been published. So then we moved on to carry out qualitative interviews with key stakeholders. And these key stakeholders were GPs, community dietitians, industry dietitians, community nurses, community pharmacists, physiotherapists, occupational therapists, speech and language therapists, and community dwelling patients. And you can see there the numbers of focus groups there. And what these showed really, I suppose, I'll summarize over the next few slides. So the first ones, I suppose, I look at are the GP's views. So firstly, we did interviews with the GPs. So we investigated GPs' views on malnutrition management and the prescription of ONS in the community. And the first overarching theme that came out was that malnutrition is a secondary concern. Okay, the first sub-theme for that was that malnutrition is an ad hoc diagnosis, where GPs express that they do not prioritise screening of malnutrition in practice, as malnutrition is seen as something associated with a disease process or social circumstance rather than a separate entity. The second theme was that overweight and obesity are seen as priorities. And the third sub-theme was a lack of resources to treat malnutrition, with GPs reporting that there are plenty of resources there for a healthy diet and losing weight, but not so much for gaining weight. And you can see the quotes from GPs here. The second overarching theme was around the responsibility for malnutrition and ONS management. And the first sub-theme that came out of that was that GPs felt that there was a need to strengthen the non-doctor primary care team, wherein GPs felt alone in treating malnutrition and identify the need for more supports in primary care to help them manage the condition. Like, it would be great if there were more community interventions. It shouldn't really be a GP. It should be public health nurses or dietitians. The second sub-theme was ownership of the ONS prescription when initiated in hospital, wherein GPs expressed there was a lack of clarity as to who was responsible for monitoring the ONS prescription when a patient was discharged, which leads to lack of follow-up of the ONS prescription. So maybe they become well and better, but because they don't have that follow-up, they seem to be continued on their ONS. And this third sub-theme was the third theme was reluctance to prescribe ONS, with sub-themes then really that they were advocates of a dietary approach. Okay, they were conservative main prescriber. They were conscious about cost. They were perceived misuse by certain patients, and they also perceived conflict of interest among those dietitians who were working for industry. So like quotes like a bit of custard pudding or rice pudding would do the job. I think sometimes ONS are not needed. You know, when you see the cost of the HSE, then you think about it. And sometimes it can be seen as a lifeline for patients to the detriment of food. So again, very pertinent quotes coming from the GPs. We also used a methodology called chart stimulated recall as part of the GP interviews, okay? And chart stimulated recall means that GPs identify the 2 charts of patients who were on ONS that the GP had seen in the previous month. And so they chose one that was less than 65 and one that was over 65, and a patient who was initiated on ONS and a patient who continued on ONS. And the themes identified via the chart stimulation recall were a lack of prioritization of malnutrition, wherein GPs were more likely to concentrate on the clinical reasons for weight loss or low BMI rather than malnutrition. So no, we haven't, because I suppose that's given the case, she's got a lot of other problems going on. It's the least of our worries. The malnutrition is the least of the worries, okay? Inappropriate prescribing of ONS was present, as GPs reported that they did not always prescribe ONS for their intended use. Did I know what I was specifically giving him? Probably not, would be one quote. And then barriers to the food first approach was another sub-theme where GPs reported lack of knowledge of the range of ONS available, and then there was safety and familiarity of the ones that they knew. And then lastly, GPs reported that they did not have dietetic services, and that those that did tended to over-rely on dietitians and didn't actively monitor the ONS prescriptions themselves. So you can see there the quotes the GPs have come up with. And then this paper was also published in Clinical Nutrition, ESPN. So then we moved on to the healthcare professionals' perceptions of malnutrition management and ONS prescribing. And I suppose the main theme that came out here was the gap in primary care malnutrition management, with the sub-themes being really 5 sub-themes. So the first sub-theme was really the limited scope of the community for malnutrition management. So for example, one community nurse saying that not being able to get support for meal preparation is just crazy. And this refers really to the home helps who are allowed to clean the patients, but actually are not allowed to prepare or feed the patients. You know, pressure sore wounds, everything suffers, but they're clean. You know, secondly, that the GPs are unreachable and completely overwhelmed. It's very hard to get the GPs, that they're the gatekeepers of care, but they're completely overwhelmed. The next sub-theme was that there's delayed treatment. So for example, a dietitian said you're prioritizing the ones that are really malnourished, whereas you should be actually able to see those patients that are at risk and prevent it from getting to the stage that it gets to. And the fourth sub-theme was the need for dietitians within primary care. And as one speech and language therapist said, you know, the dietitians as a speech and language therapists are with a network, so they're serving for 4 GP teams, okay? And then the final theme was the absence of clear diagnostic pathways and resources, as you can see here. And a pharmacist, I wouldn't know how or where to refer them to a dietitian. You can see the actual quote there. Okay. The next theme really was the challenges of ONS use in the community, and this came from all of the healthcare professionals. So really, the first one was the inappropriate ONS prescription. So again, a community nurse referring there to the fact that if a patient did get to a dietitian, she changed the ONS probably 99% of the time to something that was appropriate. Again, who is monitoring the ONS? And again, the compliance with taking them at home, and an occupational therapist reporting there that you see a lot of wastage and poor compliance. And then the perceived financial motivation of some of the ONS companies, where speech and language therapists are saying that the company dietitians push the ONS products, whereas the company dietitians themselves, the industry dietitians themselves, say they perceive that that bias is there, but they are core registered and adhere to their code of ethics and do, for the most part, work clinically. But there certainly is that apparent bias there. And that paper is under revision now with Clinical Nutrition ESPN. When we interviewed the patients, their perspectives were really interesting. And the patient perspectives on malnutrition management in the community was that it takes a village to manage malnutrition, with 3 sub-themes coming out. So the first one is really, I get by with a little help from my friends, and that refers to the fact that the majority of malnourished individuals depend on friends, family and carers to help them with shopping and cooking. So, for example, one participant said, the lad that lives next door did all my shopping for me, and another said, my daughter does the messages and I have a carer, and the carer washes me and feeds me. That carer did feed. The obvious diagnosis. And the obvious diagnosis refers to the fact that 9 of our 13 patients reported that their weight loss was first noticed by friends and family. So they reported being told things like, you're too skinny and you need to be eating more. And the third theme refers to the fact that the missing T in the multidisciplinary team. And this refers to individuals reporting that they had few, if any, encounters with a community dietitian, despite being malnourished. So once they moved outside the hospital setting, they asked, did they get any advice to help me when I'm outside of hospital? And there was none available, and they didn't have access to a dietitian despite wanting this. Community healthcare professionals picked up on this as well, so that the fact that malnutrition, picked up on the fact that malnutrition is a term to be avoided. So, this was, I suppose, something that was interesting that came out really, that malnutrition is not a term that patients want to hear. So, that it's a clinical term, and that other healthcare professionals have lack of confidence and ownership over the term. So for patients, when they heard that term, they reported that they got very frightened, or if they saw it written in their medical charts, they got very frightened by the term. And they associated with war-torn events. And that malnutrition, the healthcare professionals picked up on this, and that malnutrition was a clinical term that they didn't understand, and that even GPs say, or pharmacists there, you can see the quotes, that it was almost offensive. Or that there's a blame associated with it. So, for example, one pharmacist said, if you have a cold, it's unfortunate, but malnutrition means you've done something wrong. So the perception is there that there's blame associated with it. So they used more words like more favourable, or lost weight, or low on nutrients. And then this lack of ownership, so people weren't confident if they weren't a dietitian with using the term, so they didn't use it. So I suppose the paper that is referred to, the previous one, that it takes a village, the revisions are now under review in the European Journal of Public Health, because we felt this was a more public health journal, that it takes a village to manage malnutrition. And the one around the malnutrition term and the discussion around how we use the term malnutrition, the revisions are under in the Journal of the Academy of Nutrition and Dietetics in the US. So I suppose the summary of the qualitative interviews with our key stakeholders really indicates that there's a lack of understanding and stigma around the term malnutrition by both patients and healthcare professionals. There's poor communication between the multidisciplinary team. GPs don't prioritise malnutrition, there's insufficient dietetic services, and ONS prescribing is not evidence-based. Lack of ownership of ONS, and non-dietetic HCPs don't believe they're sufficiently knowledgeable about malnutrition to address it in practice. So just, I mean, I'm running out of time a little bit here, but the characteristics of ONS ONS users, then we looked at this. I'm just going to fly through it really quickly. We got two databases, one of all the long-term ONS users who used ONS for 12 consecutive months in 2018, and all ONS users at any time during 2018. There was 912 long-term ONS users, and there was over 14,000 ONS users at any stage in 2018. And this was from the three CHOs, 7, 8 and 9, which represent about 30% of the pharmacy claims for the country in 2018, and about a third of our population. So they were good big databases. And the long-term ONS users really, I suppose, in summary, showed, I'm just going to fly through it very quickly here, is that they were older, that they were on polypharmacy, but that younger age and being on polypharmacy for central nervous system drugs, like drugs for anxiety, were associated with higher ONS prescribed. So even though there was more older people, those who were younger were actually prescribed more units, and that this was very much associated with what we might call, perhaps, we don't know the reasons why, maybe some social prescribing around anxiety and people being unable to cook and manage themselves. So in summary, for the long-term users, older age and polypharmacy characterized the long-term ONS users, but younger age and CNS medication, particularly where there was polypharmacy, so more than 5 medications per day, are predictors of more ONS units prescribed. And this paper has been published in the British Journal of General Practice Open. When we come to the ONS users, the big group, so anybody who is prescribed ONS at any, or dispensed ONS at any stage during 2018, just to go to the summary there, males aged, more females were dispensed ONS than males, but males aged younger than 65 were dispensed more ONS units, and those in residential care were dispensed a higher volume. So again, I suppose what you're really looking at here is, you know, younger males and people in residential care with appropriate community supports and assistance should be able to manage food that's, you know, that's appropriate to their needs, rather than being so reliant on oral nutritional supplements. We divided the patients into average, high and very high ONS users, and there were clear disparities between patient groups dispensed ONS, okay, but wide variation in volumes dispensed. So it really highlights, I suppose, that there's a lot of education required. So I suppose what we did then was we took all of this and we developed this malnutrition education intervention. And the malnutrition e-learning module, we developed it in association with based on all of the information, but in association with the Irish Institute of Pharmacy, and it has 5 main modules or sub-modules within it. So malnutrition definition, prevalence, identifying malnutrition, food first advice, reviewing malnutrition, and oral nutritional supplements. And we evaluated it just in October past, at the height of the pandemic, which was really difficult, but we got 31 GPs who very kindly evaluated it. And they did the MCQs pre-post in 6 weeks, and they did the case studies pre-post in 6 weeks, and they gave us feedback, which was great. And this just shows some snapshots of what it's like, with plenty of case studies throughout, which is what the GPs wanted. And what it showed was that their knowledge of malnutrition improved, okay, quite significantly. It improved on in all of the sub-modules on all topics, especially in the identification of malnutrition. The knowledge was retained after 6 to 8 weeks. And the case studies, they were much better at calculating the malnutrition scores. The treatment that they would have given improved. The correct treatment given by 6% initially, up to 60%. And the most useful elements they found was the information on the screening tools, on the treatment of malnutrition, and the provision of the additional resources. and the feedback from the GPs was really good. So that was really nice. We presented at the ICGP, the Irish College of General Practitioners, and the Association of University General Practice conference there in March, and we won the best, it was Ashley Garrity presented it, which was brilliant. She won the best education prize, the Professor George Usher prize for the best education at that conference, which was really good given that that was our target audience. And the next step is really making this available through all healthcare professionals, all GPs and healthcare professionals. It's been done in collaboration with the HSC, and we're hoping then that it will be available very shortly. So I know that's a bit of a whistle stop through. I just want to acknowledge the Health Research Board, who are our funders, all our participating healthcare professionals and patients, our study researchers, the co-applicants, collaborators and co-authors. And it's lovely to have something at the end that the HSE is now going to take and make available, that is really going to help the management of malnutrition, because I suppose at heart I'm sort of a bit like, there is a bit of dietetics in me still at heart, even though I'm working in academia, and it's really nice to see the fruits of your academic research actually being taken then by the health service executive, by the ICGP, and actually being rolled out to the people that we want it rolled out to.